All right, well, good afternoon. Thank you for that, Marcia. Let me just thank you for the invitation, and I'm sorry that I couldn't join you earlier in the day. Let me just start by saying, my research program is wholly invested in trying to understand this challenge, and that is that, the advice that you should ask your doctor works very well for most clinical conditions, with the exception of obesity. And we are trying hard to identify ways that we can improve the ability for primary care providers to deliver counseling and comprehensive obesity care in the primary care setting, because we know, I think, and it sounds like was discussed earlier today, this doesn't happen with great frequency, particularly among those who have the highest risk of obesity. So this is a real challenge, and the determinants and the barriers to counseling in the primary care setting have been well understood. It sounds like you talked a lot about reimbursement, and I have some additional thoughts about that if we can get into them in the Q&A. We also have behavioral weight loss treatment, which presents its own set of challenges. It works extremely well, probably less well when we do translations into the primary care setting, certainly less well in higher risk populations, and it doesn't scale as well as we might like it to. And so the challenge for us in our work is to really constantly be asking the question, what's next? And so I'm going to offer some rather presumptuous thoughts about what's next, particularly as it relates to the digital treatment of obesity. It's always a little bit risky to be in the predictions game. I'm a psychologist, not a psychic, but I'm going to give it my very best shot, and we'll see what you think. Let me just say that the widespread availability of digital devices has utterly changed our lives, as probably goes without saying. And that availability of these devices, I think this penetration is sometimes surprising to people. We are surrounded by these devices, and we tend to focus on them, but far more important than the devices themselves is the data that they are collecting. And it's this data that I think we are now beginning to see really reflects the potential for us to have great change in a wide range of clinical conditions, but particularly in obesity. When I was here last year talking about digital health, I showed you this, and one of the things that I talked about was that, for the first couple of years after these digital devices were released, we did a lot of collecting. We have a lot of wearables and smartwatches and all manner of other kinds of connected devices that are collecting data all of the time. In the last couple of years, we've been developing new analytic strategies to try to understand how to parse those data, and now we're finally beginning to use those data to help to reveal clinical insights. It's been a long time coming for those of us who care about this area, but I think we're just on the precipice finally of being able to leverage these data in ways that will be meaningful for our patients. I present one example here. Almost 300 million, there have been 300 million downloads of weight loss apps in the last 7 years. This is MyFitnessPal, one of the most popular. And one of the things we're doing very simply now is using the data that these apps collect. They do a great job collecting, not a great job changing behavior, but we can create technologies that reach in, grab the data that are being collected, refine those data using evidence-based algorithms. In this case here, we're grabbing the data and using it to identify whether or not these patients are adherent to DASH. And so for these patients who have obesity and hypertension, we're able to make corrective recommendations on a real-time basis using the data that they would be collecting already. Here's an example of another trial that we're doing where we're putting scales in people's homes. They're undergoing weight gain prevention treatment. So these are patients who are not particularly motivated to lose weight. They are interested, however, in preventing weight gain. We give them scales in the house, and we give them zones. And as they gain weight, if they're in the green zone, they're not gaining weight, they're just fine. As they gain weight, they get a text message from one of our registered dietitians. As they continue to gain weight, they get a telephone call. We've known about these kind of stepped care programs for a long time. This is not new. What is new is the ability to have a low-cost digital device in homes, broadcasting through cellular networks in real time, our ability to put these data on platforms where registered dietitians in clinics can leverage them, deliver care inexpensively and efficiently. Now, at the same time, we have this in a parallel movement, really the emergence of artificial intelligence, which has great potential to change the way that we leverage these data and the way that we think about our lives. The key challenge in obesity treatment, I'd argue, but particularly in digital health treatment, is enhancing engagement, keeping patients on the hook, engaged in treatment over the extended time horizon that it takes to produce weight loss. We're leveraging AI technology now to parse data, deliver the kind of feedback that an individual patient needs at the time that she needs it, using the language that she wants. This means sort of at the end of the week, if a patient is a woman who works outside the home and has kids and likes to exercise outside and it's going to rain, then she gets a recommendation that she find something to do with her kids inside over the weekend. And so using real-time prompts that really get to know people and delivering it where they need it best. We can also be using these technologies to help to maximize treatment fit. We've heard a lot about this sort of this lack of a one-size-fits-all treatment approaches, but the real challenge for a clinician is making sense of the various treatment options. We need to allow AI to be making some of those decisions for us. Here's one of the challenges that we're working on now. Some of you might know about the benefits of daily self-weighing for weight loss. In and of itself, it produces around 6.5% weight loss at 6 months. We are using it in the context of a multi-component intervention, weight loss intervention in primary care, but it sort of precipitously declines over the course of treatment. The thing is, though, if we can get people to weigh themselves most of the days of the week, they actually lose quite a lot more weight than those who don't. So now we're using these kinds of AI technologies, beginning to think about how to leverage them to push people, give them prompts, identify when they're likely to demonstrate attrition, disengagement, and giving them kinds of recommendations that will get them on track, because we know the benefits of these approaches. We're going to see massive changes and massive emergence of digital therapeutics of all type. And the reason for this is that the outcomes, though modest now, are steadily increasing. They're beginning to look pretty good. If we look at the trials of digital health treatments that are created in the academic setting, they generally produce up to about 5 kilos of weight loss at 1 year. Commercial trials are demonstrating around the same, but we're seeing steadily increasing outcomes. But what's interesting is that these outcomes don't seem to vary very much by device. So if we're connecting through the web or text message or app or other types of connected devices, they all are in that same window, that same range. Again, allowing us to develop techniques for patients in the ways that those patients like to receive their treatment. Some of you have heard about the approach by Omada Health called Prevent. This is a commercial weight loss treatment approach for patients who have pre-diabetes. And these kinds of this sort of the commercial interest in this area has been quite cyclical, I'd say, in the last decade or so. What's changing now, I think, are new models, so value-based care models, ACOs, the CCM codes, as well as increased willingness on the part of many payers and large self-insured employers in particular to begin exploring these models to try to bend the healthcare cost curve. I think most of us agree it's unlikely to see that necessarily by treating obesity in and of itself, but we are sort of beginning to see the emergence of these models in the pre-diabetes and type 2 diabetes space, which may provide a window for other business models for other conditions. What's notable here is that even though the Omada system gets mentioned very frequently, there's a range of other technologies, commercial technologies that have emerged, some historical players that are repurposing for the DPP, and some startups that are specifically going after this kind of DPP certification to allow them to receive reimbursement to do this type of treatment digitally. And I think this is a really good sign of where things are likely to go in the next 5 or so years. Let me note, humans aren't going anywhere. The signal classic finding in digital health is that all of our treatment outcomes tend to improve when a human is involved. You see those data demonstrated quite clearly here by work from Deb Tate from a while back, and this is just, add a basic email to a standard internet intervention, you get better outcomes. Larry Apple, colleague at Johns Hopkins, demonstrated this quite elegantly a few years ago, showing that it really didn't matter whether you contacted a patient on-site in person or via the telephone, a different type of provider. These are wellness coaches. You tended to produce similar outcomes at 2 years, around 4.5 kilos of weight loss in a primary care-based trial. Both of these suggest that adding humans to technology approaches tends to produce better outcomes and strongly suggests that this is the way we should be rolling it out. Technology serves, in my view, to improve the efficiency and the quality of human-delivered care. It doesn't really supplant it. And finally, I think what's really important to note here is that any time we start talking about digital treatment, particularly of obesity, given its remotely delivered nature, there is a temptation to try to argue that physicians and other primary care providers should be cut out of the process. I'd like to argue that providers have a really important role in both triggering the cascade of different care options, coordinating care, and serving to hold the patient accountable. We know patients want that kind of accountability. They want to be treated by their provider. And I think we need to better armor our providers, particularly in the digital space. we just finished a trial called TRACK where we situated a digital intervention, linked it with the electronic health record. This is a digital intervention for weight loss in the primary care setting. And we situated it at the nexus of providers. These are primary care providers, program coaches who are registered dietitians, and our patients. After 12 months, you see about 4 kilos of weight loss, which compares pretty favorably to what you saw from Larry Apple in his trial a little while ago. But what I want to point out is much more interesting in my view. What we did here was that every time that as our patients were going throughout their day, tracking, using their app, and talking to our registered dietitians, we would create a very short counseling recommendation and drop it into the electronic health record for our providers to use. These are very, very specific recommendations. It says, please reinforce continued participation in the study. Tell them not to work on portion control and no sugary drinks. Simple, straightforward, basic advice that could be read to a patient. If a patient told us that their provider counseled them on diet or exercise in a very generic way, we saw no effect. But if a patient told us that their provider counseled them using this guide, reinforcing participation in the study, they lost an extra 4.5 kilos. My suggestion here is that providers have an important role of holding patients accountable, and we need to armor those providers to do what they do best. Finally, let me just say that I think this approach really helps us to reach, engage, and treat our patients at highest risk. We know that there are new digital divides, such that those at the lower ends of the socioeconomic spectrum, many racial and ethnic minority groups, are more likely to own and use their smartphones. All the data that I showed you today that I described as mine was collected among extraordinarily socioeconomically disadvantaged, medically vulnerable patient populations, often in community health centers, in rural settings in North Carolina. So this is not highly motivated patients. These are patients who have obesity and a range of other cardiometabolic conditions. They benefit similarly, and they engage at a very high level. Last thing I'll show you is this. When we ask our patients to use our apps, in the last trial that I just mentioned included the provider, we asked them to track using our app at least once a week for a year. At the end of the year, 93% of this medically vulnerable audience was tracking at the expected rate. So I'll submit to you that this is the kind of approach that can reach and engage all patients. It may be, I actually think it's an ideal approach for reaching into historically disconnected populations and allowing us to ensure that we're delivering comprehensive care from providers in the way that suits them best. Thank you.